Alright, so everyone's looking a bit scared because I'm an exercise physiologist, and I am going to test you, because Julie's nicely pointed out some fit and healthy people in the room. So what I'm going to get everyone to do is just take a seat at the end of their chairs, if you don't mind. Just at the end of the chair, maybe push back a little bit. I'll demonstrate here for you. And if you have an injury, I'd like you to remain seated if that's okay.
Can I just quickly say, and then I'll shut up, I'm on the cusp between people encouraging me to exercise and people wanting to prevent me from falling over. That's 65.
Alright, so where we are, standing up, sitting at the edge of your chair, back nice and straight, feet about hip width apart, and all we're going to do is take 4 sit to stand. So what that looks like is just coming up tall and back down. Good. 2, very nice technique everybody, it's lovely. Good to see. 3, and on the last one we're going to stay standing. I'm going to come down and it's going to take 5 seconds for us to sit down. 1, 2, 3, 4, too quick. 5. Well done. Alright, and just a stretch to finish on. If everyone can just put one hand out to the side, the other here, and then bring it together. Okay. So guys, just quickly to introduce yourself. I'm Oscar, I'm an exercise physiologist, and I work mainly with young people with emerging psychosis, or with first episode psychosis, in Prince of Wales Hospital over in South Eastern Sydney Local Health District. But as Julie said, I'm also now teaching a lot of mental illness within the exercise physiology courses and medical courses at UNSW and Wollongong. I really want to quickly start off by talking to some of the stigma, and I use some of these slides to talk to my students because there is still a bit of poor understanding about what mental illness is. And it's important to recognise that we have this spectrum between severe mental illness and then the general population. And it's important to recognise that people with a severe mental illness, they can have good mental health and they can also have poor mental health, and that those symptoms fluctuate throughout life. Similarly, someone without a mental illness can have good or poor mental health. Okay, so it's really important to recognise this because when we talk about the research, some of the research around exercise and mental illness is focused on the general population's mental health. Other research is focused on mental illness and symptoms within that. So just important to recognise. So a lot of us here work within mental health, and we all kind of know what a mental health system in Australia looks like. But it's important to recognise that some of the key aims are to reduce or minimise symptoms, focus on psychosocial recovery. We obviously know that there's a medical component of that, where we're using medications to help manage symptoms. Sometimes we have this common situation where there's multiple medications that are used, and we know that some of the side effects can be detrimental to health. But important components of psychosocial recovery is we have this psychoeducation, focus on vocational, getting people back to jobs, work, study, family support and education, cognitive remediation, and then looking at physical health care. And this is where I think there's a key role for people like me as an exercise physiologist and dietitians, but also for general practitioners, psychiatrists, psychologists, to be aware that this is something that you don't have to be a qualified exercise professional to be able to help people getting healthy and active. So our common mental health team, at least the team that I work in, is a team of psychologists, social workers, occupational therapists. We also have now smoking cessation specialists. I'm an exercise physiologist and dietitian, and we want to very much encourage the role of peer support, so people with lived experiences working within our programs and being able to help people through their lived experience. I left that here for my students because it's often one that's very confusing, so if anyone can give me the answer, I'm still waiting. So here we're talking about 2 silos of mental health, where I think this is what we think about the traditional models of mental health treatment, where we have the mental health care on one side, which is the neck up, and then everything else is somebody else's problem from the physical health care perspective. And what we want to do is try and break down these 2 silos of physical and mental health care, where we see the role of exercise physiologists and dietitians coming together to try and break down these boundaries. And the reason why it's so important is because we know that there's this bidirectional relationship between physical and mental health care, mental health. Some of the evidence is showing us that people with an increased risk, of developing mental illness, if they experience a range of chronic health conditions. Okay, and I think a lot of us can also attest to that is when we see people coming with a range of different diagnoses like cancer and chronic pain, there might be some comorbid mental health condition as well. Similarly, people with a depression diagnosis actually have poorer health outcomes when they're being treated for their chronic health conditions. So in terms of looking at changing policy and cost effectiveness, this is some of the things that are important. Looking at poorer treatment compliance, greater risk of complications, longer stays in hospitals, and worse recovery outcomes. So it's something that's really important when we're talking about a holistic healthcare model. In terms of people living with psychosis specifically, this was a large SHIP study which looked at the rates of chronic health conditions with people living with psychotic illness. And interestingly here, 2/3 were smokers, 75% were overweight or obese, and 85% had increased central adipose tissue, so meeting criteria for metabolic syndrome. 43% had these adverse effects of the antipsychotic medications. I'm sure a lot of us are aware of the effects of antipsychotic medications, but I'm going to talk to that in a little bit more detail. And you can see the high rates of chronic health conditions here as well. So I'm sure most people have heard about the life expectancy gap, but if you haven't, there's about a 15 to 20 year gap in life expectancy between people living with a severe mental illness versus the general population. And you can see here that the life expectancy gap is actually going down. So the gap is increasing and the premature mortality is going up as well, and life is decreasing. So what we know that a majority of the contributing factors to this, when I talk to my students, they think it's suicide, but we know that the greatest proportion is actually cardiovascular related health conditions. Okay, so we know a lot of these conditions are actually preventable and modifiable. So this is where we see the role of prevention in terms of lifestyle as well as an important component of health. In terms of what the data says, and just finishing a PhD, I get very excited by numbers all of a sudden. And this was a really large study which looked at a huge population level, and it's looking at the rates of cardiovascular disease and risk in people living with a severe mental illness. And you can see 53% have a high risk of CVD, 78% have a high risk of developing CVD, and 85% have a high risk of death from CVD. So this is a big problem. It needs to be addressed within a mental health care system. Importantly, the risk of cardiovascular disease or cardiometabolic illness increases with illness severity. So when someone's not on medication, it's about a 6% increase, which is interesting that it's different. It's not just the medication. There must be something else happening here even before medication comes involved. When someone has a first episode, the rates increase, and then with established mental illness, you can see it's a lot bigger. So we spoke briefly about antipsychotics, and we know that there's a couple that are particularly bad in terms of what they cause in terms of weight gain. And olanzapine and clozapine, which is similar properties, we know that are really, they very severely impact health through weight gain. And you can see this is quite an alarming graph that looks at the changes in weight from when someone starts antipsychotic medications at day 0, and 24 months, there's about a 12 kilo increase in weight. Okay, so it's rapid. And we know that a lot of that weight is disposed around centrally, okay, which leads to things like metabolic syndrome. And you can imagine for a young person just starting mental health treatment, what that might do for self-esteem as well, and adherence to medication. So us as exercise physiologists and dietitians, we're aware that it might be on the agenda to manage weight in these young people, but also looking at what else can we achieve through exercise and lifestyle when weight gain does happen, and trying to shift the focus purely away from weight, but looking at things that can improve health like fitness and sleep quality and mood. Okay, so I'll talk to some of that evidence as well. I really like this quote by a psychiatrist in the UK, Graham Thornycroft. If such a disparity in mortality rates were to affect a larger segment of the population with a less stigmatised characteristic, we would witness an outcry against a socially unacceptable destination. So it sort of talks to the diagnostic overshadowing that we see in mental health care, where if someone has a diagnosis of, say, schizophrenia or major depression, that's only what they get treated for. They don't get acknowledged for any of the physical health complications that happen. And one example is I had a client when I first started working who I asked to take his weight, so I asked to take his shoes off, and there was blood around the cuff of his jeans, and I asked him what's going on there. He had no idea. Turned out he had severe microvascular damage and peripheral neuropathy from poorly controlled diabetes, and no one had looked at it. He was in a residential facility where there's nurses around all the time, and no one had acknowledged it. So this is something that's actually happening in the real world. And we want to try and avoid this situation where the mind and body are getting treated by two different professionals as well. In terms of diabetes, we know it's such the silent killer in the general population. What we know is that there's much higher rates of diabetes within people with a severe mental illness, and you can see rates here differing between diabetes prevalence and relative risk in people with major depressive disorder, bipolar, psychosis, generally across the board, and then specifically schizophrenia. So it's a big problem within this population group. So this is becoming acknowledged within the health system, and we now have these metabolic algorithms that we as a whole team use to identify those that are at risk versus those that in the healthy ranges and those that require intervention. So this one's developed by colleagues within Sydney, Jackie Curtis, and people within the UK, including David Shies. And you can see physical activity has a key column here in terms of cardiometabolic risk, and then other factors relating to lifestyle, including smoking, diet, weight, blood pressure, and other sort of cardiometabolic risk factors. So this is a good tool that could be used to put in the wall of all sort of GP clinics and different settings to identify where your patients fall in, and then what needs to be done in terms of intervening. So specifically to start talking about exercise, and we know that exercise physiologists, our main role is to kind of address these modifiable risk factors. Definitely eating behaviour and smoking is something that we can work in terms of lifestyle change and behaviour coaching. But I wanted to explain this complex situation that we have there, this bidirectional relationship between all these outcomes and how it can affect mental and physical health. So very briefly, I want to talk about stigma around exercise. So a lot of people think to get involved in exercise, you need to be, getting your Lycra Day hair peroxide blonde and get a Fitness First membership. But Julie's identified that you can start at 65, and it doesn't have to be that case where it's about image, it's about health. And I think it's so important to talk about the differences between planned or incidental exercise and structured exercise. Both things equally beneficial for health. Okay, and we know that not everyone likes gyms, so some options that we have here in terms of aerobic and resistance exercise, things that we've done just here today, but also walking and jogging and things that we do that get the heart rate up are really important in terms of aerobic. And then incidental things like some things I use to get people who are very sedentary is just trying to walk to the bus stop and an extra stop before they then get on the bus. Just really small, realistic things, taking the stairs rather than the escalators, gardening, housework, things that are really important. We all know about our food pyramid that the Australian government tells us about, so I've created an exercise pyramid in terms of what's recommended and where our discretionary foods are, so our Mars bars are our seating. Okay, so this is what we should try to be doing in moderation, as little as possible. And then we've got strength training 2 days a week. Some people, if you're wanting to build muscle, obviously is more important. Aerobic exercise, we should be doing 30 minutes at least 5 days a week where we get the heart rate up. And then unplanned lifestyle, we should be doing this all the time. So people should be trying to be as active as possible throughout the day. Exercise and mental illness, so what's the association here? So specifically within young people with psychosis, this was a study that looked at what were the correlates, what was more likely that someone was going to be physically active, so meeting recommended guidelines. These are the proportion of people that met the physical activity recommended guidelines, and you can see overwhelmingly, majority of the people weren't, okay? And these were some of the predicting factors that made people more active, so those that were younger, those that were studying, so higher functional capacity, so this association between function and physical activity levels. Those that weren't on psychotics, and we know that a lot of antipsychotics have a sedative effect, so people become less active. Social dysfunction. Loneliness is a really important risk factor for physical activity, and it's something that there's an emerging area of research. Healthy BMI as well, and increased waist circumference. Interestingly, this study found that those that were achieving the 150 physical activity minutes versus those that weren't achieving those guidelines, and someone's risk. Okay, so if those people weren't achieving the recommended guidelines, just as an example here, they are 1.8 times more likely to have increased abdominal obesity, almost 5 times more likely to have hypertension. So just to talk to the effects of exercise, it doesn't necessarily need to be about weight. It's actually about health and cardiovascular risk, okay, and prolonging life. So in terms of people with mental illness, we know that there's, Oh, yeah. 5 more minutes, okay, cool. I'll rush through this. There are a few barriers, obviously, that people with mental illness, and importantly, we know that exercise works, okay? It works with improving symptoms of mental illness, it helps improving the physical health in terms of cardiovascular risk, and it helps with improving functional capacity as well. And importantly, all of these improvements can happen independent of weight. So this is, if it was up to me, I'd be throwing the scales out of the clinic and just focus on how people feel and how people's noticing changes within themselves. I've massively underestimated my time, but I'll quickly talk to that. In terms of prevention, we know that those that are more active in your earlier ages are at reduced risk of psychosis and major depression later in life. So looking at early intervention strategies, physical activity should be a core component. Fitness is essential as a risk factor. And just looking at this, so imagine a conference where we have mental health delegates. This is what we're starting to do to get physical activity on the agenda. And we actually have exercise bikes in the conference hall, and we're testing delegates to try and talk about the benefits of fitness and physical activity and get exercise physiologists integrated within mental health teams. So this is Pat McGorry, who started Headspace National. He's a big advocate for physical activity, and we now have exercise physiologists employed at Headspace, Bondi Junction, Castle Hill, and it's growing. Okay, so there's an emerging role, and I'll leave it to questions for now.
We've got time for a couple of questions or comments, so please, thank you. And can you just say who you are and where you're from, and I'll hold the microphone.
Sure. I'm Clement from New Access, beyond the program for anxiety depression. I just want to thank you for this presentation. Can I get a copy of this presentation, please?
Yeah, sure.
Well, look, I'll find out too from the organisers whether they can go on the website, but thank you. Other questions or comments? Sorry, darling. Anyone got a question or comment? I'm happy to run to you because can you see this is assisting me, this is movement. And I've got osteoarthritis that won't move for me. Can you introduce yourself?
Sure. My name is Laura Garcon. I'm from the Sydney Local Health District Mental Health Service, and I work as a GP liaison. I just wanted to say, and I could hear the reaction in the audience of getting rid of all the scales. What a fantastic idea that is. I know we tend to be really empirically driven, but making it all about how you feel and what's happening for you, I think is just an amazing idea. Thank you.
Any tips on... some of us have a lifelong pattern of overeating to feel better. And as I say to one of my doctors, it works. And she says, I'm not even joking, she laughs too, but anyway. And she says, no, it doesn't, Julie, because you're struggling with overweight and, you don't survive cancer in order to get cardiovascular illness, so to talk bluntly. So you say you mentor and coach around that. Tips, when you've got a lifelong pattern, to change that pattern, what sort of support do you need?
I think it's a really hard question, and we all, like someone spoke to earlier about, everything in moderation, the French style, making sure that you're enjoying life. I think that's really important, and it's not, I think we try and throw out the ideas of dieting. I think that never works, and actually one of the most dangerous things is fluctuating weight. So when people are on these fad diets and they read things in the media about how they can cut weight quickly, we try and avoid that. It's quite dangerous. So I think it's more about looking at very realistic and small, achievable things that you can do to swap out. Maybe looking at cutting down soft drinks from 2 bottles of it to 1, and things that are very realistic. And I think dietitians are really good for that. You can access dietitians through chronic disease management plans where you can get, rebates on those sessions, and they can help with just realistic changes rather than anything overly dramatic.
Well, look, one of my nephews is just about to qualify from the University of New South Wales as an exercise physiologist, and now I know what he's going to do. It's been enormously helpful. Would you please give this gentleman a warm